Welcome back. I was thinking about this session and thinking this may, in some ways, be the driest of the sessions. But maybe not. It depends on how much you are interested in engaging in arguments. And there are lots of arguments today, arguments around the ethics of suicide, around assistance in suicide, about the whole meaning of those activities. And so if you find that engaging, maybe not so dry. I wanted to begin by sort of indicating these are not all the pathways to death, obviously, but they are some of the more prominent ones. Removing or not starting futile or non-beneficial life support with palliative measures. We talked a little about this last time in the sense that psychologically it's harder to take away something that's supporting life than it is not to start it. But not to start it frequently is a way of just guaranteeing a certain kind of outcome. So lots of things, lots of technologies, and especially in intensive care units, are tried for a while to see if they're going to be helpful. If they're not helpful, the logic of taking them away is the same as not starting them. If it isn't helping the patient, then they shouldn't be receiving it. But psychologically, it feels much more difficult to take something away, I think on the part of clinicians, but also on the part especially of families. A second mode of ending life is voluntarily stopping eating and drinking, and I want to touch on this just a little today, near the end, but session 6 we're going to talk much more about this because it has some very complicating features. Sedation to unconsciousness, which happens when a person's pain cannot be controlled by the usual methods, and the only way to make them comfortable is, in fact, to make them unconscious. This is a controversial measure. It's practiced sometimes in hospice, I don't think terribly often, sometimes in hospitals, I don't think terribly often, sometimes it happens and it isn't discussed, but it constitutes a mark in terms of the intervention. To sedate someone to unconsciousness is, in a sense, to guarantee their demise. And it feels more active, right, than just letting a person die of so-called natural causes. Physician assistance in suicide is the topic we're going to spend most of our time on today, the one which gets most of the press, and one which it seems to me is a practice whose time has come culturally. And I'll talk a little bit more about that in terms of the spread of this practice, the legalization of this mechanism of dying in the United States and beyond. And finally, euthanasia, by which I mean the active killing of someone, such as the injection of a lethal dose of a medication, where the intent is to kill them. And this is perhaps the most controversial of these practices I've listed, but it is legal in some parts of the world, as you may know. All of these involve some degree of professional expertise, and usually, I think almost always, family support to pull them off. You may remember the case of Brittany Maynard from 2014. It got a lot of publicity. Brittany Maynard was a 29-year-old young woman who was diagnosed with a glioblastoma, which is a very aggressive brain cancer. She and her husband moved from California early in that year to Oregon because at the time California did not have, as it does now, a provision for physician assistance in death. And she had calculated she wanted to die on November 1 in terms of her symptomatology and how severely ill she was feeling. She had stroke-like symptoms. She also had tremendous headaches and seizures. And as these began to get worse and worse, she began to calculate what the right time might be. At one point, she said, November 1 is going to be the day. But November 1 arrived, and she decided, well, maybe not yet. My quality of life is still sufficient. And I think it was later that month that she finally did take the medications. And this was a part of her goodbye message, which you can read. She talks here about dignity in the face of terminal illness. She says it would have taken so much more of me, and it had already taken quite a lot. The whole process of making physician assistance in suicide legal stems from a Supreme Court decision, Washington v. Glucksberg in 1997. And let me give you a little bit of background to why this made it to the Supremes at all. There were two U.S. Court of Appeals rulings in 1996. Here's one of them. This is the 9th District Court, which is the extreme western states, California, Oregon. They ruled that the ban on physician-assisted suicide in Washington state had to go. They lifted the ban, and this was their reasoning. An individual has a strong liberty interest in choosing a dignified and humane death, including not just refusal of treatment, but hastening one's own death. So this is the Court of Appeals for the 9th District. They said, yes, this is something people who enjoy liberties ought to have. At that same year, the Second Circuit Court, which is a northeastern court with jurisdictions over Massachusetts, Vermont, and New York, ruled that a New York statute criminalizing assisted suicide was unconstitutional in its effect on terminally ill people. And this is their reasoning. Because existing laws permit terminally ill persons to remove medical interventions and receive palliative treatments that may hasten death, those who wish to hasten their death but are not dependent on some piece of technology like a respirator or a feeding tube are treated unequally, and therefore they are entitled to the same assistance. Now, this is a way of reasoning which crops up a little bit later, but I think it's interesting. This was the reasoning of the, the Second Circuit Court. And what happened when this reached the Supreme Court is that they ruled that both of those lower court rulings are invalid, because they said there is no constitutional right for assistance in committing suicide. It's not something to be found in the Constitution. Therefore, you can't guarantee it to people. They said it's not one of those fundamental rights and liberties. This is precisely what both lower courts had said. But the court left open in their judgment. Sandra Day O'Connor was prominent in writing this part, actually, of the ruling. People are entitled to the palliative care that they need, relief from suffering at the end of life. And while there isn't a constitutional right to assistance in suicide, they left open the question of whether or not it was permissible. So that left the states in a position that they could pass such legislation if they so desired. So this is the ruling that sort of opened the door. This is also the same year that the Oregon Death with Dignity Act, the first of these, was passed. And just to remind you about the kind of provisions that are in that act, it has a number of safeguards. The patient must make a request. There have to be 2 oral requests and 1 written request. The waiting period between the first and second request is 15 days. Then there's a 48-hour waiting period between the receipt of the written request and the prescription for the lethal drugs. So 2 time periods built in here. Obviously, they have in mind trying to prevent people who just ill-considered and out of a panicky, perhaps, response would seek this. So these are sort of waiting periods that are built in for, I think, the patient's ability to deliberate a little bit longer. Is this really what you want? Witnesses are required. One cannot be a relative, one can and one cannot be. And also, the second person cannot be a beneficiary or an employee of the institution where one resides, or of the doctor who writes the lethal prescription. In terms of the capacity of people making the request, the Oregon provision says the patient must be referred to counseling if psychiatric or psychological disorder is suspected. This became a big bone of contention because some people claim that the general internist, who might be the recipient of such a request, is not especially well trained in diagnosing depression. Now, whether or not that's true, I'll leave to your judgment. Probably there's great variation in that capacity. But of course, this was not a requirement for physicians. It was always optional, and everywhere I've ever heard there's legislation, it's always an option. Physicians can participate in this way or they cannot. Interestingly, the surveys of doctors continue to show roughly a 50-50 divide in terms of whether or not they think this is a good thing, not about participation, but whether or not they think this is an appropriate thing for our medicine to be doing. If anybody has questions as we're proceeding through this, yes, sir?
Is it a requirement for the patient to be sick?
Yes. Sorry. Is there a requirement that the patient be sick? Yes. Almost everywhere but Canada. There's a provision for a 6-month foreseeable death. So it's the same as the qualification for hospice care. I'm sorry I neglected to mention that. It's quite important, yes. So this is not intended at all to apply to people who are not terminally ill. That's the intent. Yes, sir?
Why is it so difficult for the states to execute someone with a triple dose of poison and then they suffer for 30 or 40 minutes? And here you can put them to sleep and die.
Okay, so the question is, why is it so difficult to put, well, capital punishment, essentially? Yeah. That's a whole nother ball of wax. And the question of how we feel about capital punishment, I think, probably doesn't figure into anyone's thinking in terms of what the provisions of this might be. Now, having said that, of course, there's going to be somebody out there who said killing is killing, and, you know, it's just...
His question is about
the mechanics. The mechanics.
The drugs that can be used here that
Yeah.
and the drugs that are used in capital punishment, are those different? This is not part of the course, so maybe...
Yeah, and it isn't part of the course, and honestly, I don't know. I mean, are they using different drugs? Yes, I suspect they are, but I really don't know. Why is it more difficult to execute people than it is to assist them into suicide? One more question. Yes, sir.
No provisions for dementia patients who may not be able to
Nope,
do this by themselves.
not in Oregon. Not in Oregon. This is not a right to be killed. This is a right to request assistance. Really, really big and important difference. Although you might like Canada's law when we get there. Here's the point that was made, right. 2 physicians must agree that the death is likely within 6 months, and physicians can opt out, as I mentioned. These are statistics, the most recent ones I could find since 1998, of those who received a script for lethal drugs, which was 1,545 people. Roughly 2/3 used the drug. It's a very consistent pattern. And the demographics of the people who choose this means typically well-educated males. Not altogether males, but the typical person who pursues this course is a well-educated male who is insured, frequently enrolled in hospice care.
Probably don't have it, but 1545 over 20 years, it just strikes me as a small number. And I wonder if you have even a guess or an opinion as to whether that shows us that it's still only a small percentage of eligible people that achieve.
This may be an answer to your question. Y'all are so good. You're just right on the money here. So you can see that the use of this provision has gone up. So the blue line is the number of deaths. The orange line is the number of prescription receipts. And it's been consistent. It's about 2/3 all the way along. I think the provision just became better known. More people avail themselves of it, but still it's a small percentage of the population who die every year who availed themselves of this. I don't know the numbers in Oregon. I know that in Canada, in 2 years' experience, it's been less than 1% of the deaths. One of the most interesting things to me is, why are there a larger number of people who request and receive the script as compared to the number of people who take the medication? What's that about? What would you imagine?
They've done it before.
Yes.
In Oregon, it's people will die before they're able to use those.
People may die before they're able to do so. That's certainly true. Yes, sir. Yes, the family might discourage them from doing this. Yes, sir.
Safeguard. Person's got a way out, and they don't always need it. That's 6 months.
I think this is true also, that a lot of people feel, I want a way out if I feel I really have to do it. And maybe I won't. But if I do, it's in the drawer, right? I can get to it. So the sense of control of timing is, I think, continues to be a very important element in this question about who finds this, an important avenue to pursue, and then why. Why would you do it? Well, stay in control as long as possible, I think, or have the kind of death you think you really want. But the question of timing is a tough one, right? You can wait too long. You can wait until the point in time in which you can't do this yourself. Then it becomes something else. Then it's, well, is it still suicide? How much assistance do you have to have before it becomes a death by another person, right? Remember Jack Kevorkian? Jack was so great. He was, in the trials, he would say, I was just helping people out who wanted to get out of suffering. And I wasn't really accountable for their deaths, even though, of course, he hooked them up, did everything for them except push the final button to start the drugs. That's the only thing he didn't do. So is that such a big assist that you want to say, this is a little worrisome? Now, they finally got Jack convicted because he used carbon monoxide with a patient. Carbon monoxide has no pain-relieving quality, right? It's not a medication. It's a way to kill people. So they said, we don't think this is going to stand up. Your means of helping people out of life isn't consistent with what you say your motivation was to relieve pain and suffering. Unless by that you mean, you know, this is a way to relieve pain and suffering, right? You can terminate their life. Yes, sir. Does life insurance have anything to do with these numbers? I don't know. I have seen policies in which, you know, if you kill yourself, the policy is null and void. I have also seen policies which don't have any such provisions. But I honestly don't know the answer to your question. I've seen them with a 6-month and with a 2-year, 1-year time period. Yeah. Depends on when you take it out, I guess. Yes, ma'am. Last question, and then we'll move ahead.
Okay. Do you know what the residency requirement is in these states that have physicians that have?
Great question. What is the residency requirement for these states? I don't know for sure. I think it's about 6 months. It may be longer than that. In Canada, you can't, they wanted to eliminate what they call tourist suicides. So they said you have to live in the country long enough that you're eligible for the National Health Service in Canada. And I think that provision is longer than 6 months, although I'm not sure about that. Any Canadians in the group? You think it's 6 months also? Okay, thank you very much. These are the other states: Washington, Vermont in 2009, California and Colorado in 2016, the District of Columbia also in 2016, Hawaii last year. And all the provisions are very similar to Oregon. Oregon really created the template for how state legislatures would think about this. Montana is a little different. They had a Supreme Court ruling, 2009, 5-2, Baxter v. Montana. Nothing in the state law prohibited a physician from honoring a terminally ill, mentally competent patient's request by prescribing medication to hasten the patient's death. The state legislature has never passed anything. But most people think you might be okay, you know, if you follow the rules. In Montana, I don't have any statistics on how often this happens. Canada is very interesting because they legitimated not only assisted suicide in the strict sense in which we've been talking about it, a lethal prescription from a physician, but it allows practitioners to euthanize, okay, actively kill, right? Patients who want to die but are physically unable to kill themselves. I don't know how many times this has happened. I couldn't find statistics. Other interesting parts of the Canadian provision: it does not allow assisted suicide or euthanasia for those diagnosed with mental illness. Now, it doesn't talk about a suspicion of depression, which is in the Oregon law. This is a diagnosed mental illness. But if you are in the Netherlands, Belgium, or Switzerland, that's not so much of a problem. In Canada, you must be 18. You have to have 2 requests, 10 days apart, 2 witnesses. Again, very similar to what Oregon has done. Interestingly, the Canadian law is vague about what counts as reasonably foreseeable. They don't have a 6-month provision. It says that death must be reasonably foreseeable, which could be a longer time period than 6 months. Canadian law allows physician-assisted death for patients whose conditions are grievous and irremediable. So they've avoided this language of terminal illness. Grievous and irremediable. So clearly it's open to some interpretation. Yes, sir?
Does that mean Alzheimer's
Possibly. The interesting thing to me about the Canadian law is that it gives the physician a lot of latitude. Now, you have to have two physicians agreeing to this, but there is some latitude here. So I would think that perhaps, at least in the judgment of some people, that would qualify. Yes, sir. I'm sorry.
I wondered if this means that Alzheimer's patients as well.
Alzheimer's patients, yeah. Yes, sir, and you're going to have to stand up and talk loud.
Is the 6-month provision with or without medication? In other words, with medication, the person can go for 2 years. If he says, I'm not taking anything, and it's 3 months.
Doesn't stipulate whether it's 6 months or with or without medication, you know. By this time, most people have gone through all the possible medications, though, certainly in the United States in terms of those provisions. This is what they had in mind, that, you know, nothing has been really effective for you. Okay, yes, ma'am.
Do the states, the doctors that provide these services, do they have to report this somehow to some higher or somebody else?
Yes, they do. Yes, they do, and I wish I knew who they report to. I suspect it's the state health authority that the report goes to, because most of the states really, I think probably all of them, they want to compile statistics. They want to know how often this is being done, and they also want to be sure that there isn't an abuse of this kind of provision. Yes, sir, one more.
Perhaps you touched on it already, but given, say, a terminal diagnosis of cancer, and you decline any treatment, in other words, there are treatments available that could significantly prolong your life, does that impact your decision whether it's valued or not?
Did you get the gravamen of his question? Yes. If you have an illness for which there is some, potentially at least, some treatment, and you've declined it, does that disqualify you? No, it doesn't. Because the right to refuse treatment, even a life-saving treatment, is one of the most fundamental provisions of both ethics and the law in the United States. One of these fundamental liberties. You can't do anything to me unless I agree to it, period. Even if I would benefit from it, even if it saves my life. Sure.
Constitutes a lethal prescription when many patients are being prescribed prescriptions quite capable of taking their death if they alter the dosage.
Did you get the question? What constitutes a lethal prescription? You could presumably have access to drugs otherwise that, if taken in the right dosage. I'm so glad you asked that question. Because why would anyone want the assistance of a physician? Yes, you want to get it right. The thing that patients who contemplate suicide, the thing that is most fearful is that you will fail because you'll get the dosage wrong, or you won't take enough, or something will happen along the way to interrupt you. Okay? So if you're serious, you want help. You want to achieve your end. The fear of trying and failing is a tremendous fear among people in this situation. And that is so very different from what we typically think about suicides in terms of the psychiatric element, where suicidal ideation attempts are usually thought about as cries for help. I had a good friend who was a surgeon in North Carolina who tried 7 different times to kill himself. He ran his car at top speed into a tree. He drank 3 gallons of gasoline. He took sleeping pills. They finally finally got a handle on his diagnosis. He was so deeply depressed. And now he's living a good life. And he says, thank God, they found me in time. But that kind of scenario, of course, has colored the way we think about suicide and suicide attempts and assisted suicide. But of course, it's not the same. Yes, ma'am.
Are there various cocktails that different states use or different doctors use, or is it basically the same cocktail that's given all the time? And when I say cocktail,
Are the same lethal drugs used in all the states? I have no idea. I have no idea. My suspect is there are probably only a small variety of drugs that are in use, and it's reasonably standard.
does it just put you to sleep?
Yes, and you don't wake up. That's the idea. Yeah, I don't know. Bob, do you have any ideas about this?
I would think, just like you said, that there are only a few drugs that work like that. And you want to get the dose right.
Yeah. So I suspect there's a kind of a standard practice here that if we only knew, is the accepted way to do it. Yes, sir.
I'm sorry, but in the paper the other day was an article about a type of, I believe it was a type of cancer that was just totally incurable until this drug company discovered this medicine. Now the medicine, a 20-day supply, is $375,000.
Yeah.
Now, where does economics, I mean, I couldn't afford $375,000, for 20 days.
Yeah, the whole business about newer drugs which would extend your life for a short period of time, extraordinarily expensive. I haven't seen one yet. I can't think of one because I try to follow this, which would really cure you of the illness you have. Most of the time, one is trading a $300,000 drug for an extra month or two of life rather than a cure. So that doesn't speak to the horrendous cost and the problems with regard to the high cost of drugs in general. But yeah, yes. Secobarbital is your response to the question, what do they use?
Secobarbital is considered the best way for suffering individuals who want to control the manner of death, including administering themselves. Barbiturates of choice, quicker onset, duration is such that the dying period is reduced, and so on. Used in many foreign countries, and just last year, 17 made it in Canada.
Did you all hear that over on this side? Okay. All right, let's keep moving. In Canada, since 2016, 3,714 persons have died with physician assistance, and this is about 1% of all deaths in Canada during that same time period. So it isn't a very large number of people anywhere. The United Kingdom, in the UK, lots of surveys and lots of discussions about this. The British Medical Association is officially opposed. The polls indicate that about 50%, both physicians and citizens, favor a law permitting physician-assisted suicide. Interestingly, it's about what it is here. National polls of citizens show between 50 and 60% would favor this kind of legislation, generally speaking. You had a hand up.
Well, one of the things in the U.S., at least as I'm hearing it, is that there's...
Stand up.
Yeah.
Stand up.
There's-
Sorry, it's the price of asking a question. Yeah.
So, one of the things that occurs to me is that in the U.S., there's an assumption in this, to my ears, that everyone has equal access to healthcare and treatment, which isn't true.
Which
You
is
know?
not true, categorically not true.
So I can have a cancer that if I get the right medication, I might live 5 more years, and if I don't get it, I'm going to suffer tremendously. You know, I mean, there's lots of cases of that. So in Canada, you do have broad-based healthcare where people get access, and I'm just wondering how the statistics compare. And then these other countries, I'm not so sure. But I thought in Canada you can get treatment until it doesn't really do whatever you thought it was going to do anymore. So
Okay, so the question is roughly this. If you had a national health care system where everybody was covered, would it make a difference in terms of the numbers of people who might choose this route to end their life? I don't think, I'm always in dangerous territory when I'm talking about this, but I don't think you can make a correlation like that, because one of the great fears when Oregon first passed the legislation is that people who lacked insurance would either choose this themselves or they would be, kind of urged into it by their family members or neighbors. It just has not been the case. And showing you the profile of people in Oregon, at least, who have used this provision, it looks to me like being married. Being male is dangerous, yeah, for this. Being single, and people who were fairly well educated and had health insurance. Many of them were in hospice care. So it's not the downtrodden, it's not the poor. It's not that people are being shepherded into assisted suicide because they couldn't get health care otherwise. It seems to be people who just really want this degree of control about their death. And, males are bigger control freaks than females, generally speaking, and have more macho attached to, what this is like. I know that's true for me in comparison with my spouse, for example. But anyway, you want to follow up?
yes.
Okay,
because-
stand up
All right.
and face this way.
All right. So the other thing that occurs to me is that if I am poor or don't have health access, you're talking about health assistance. So again, I think there's an assumption that sits under this about access that if I don't have health care, you're talking about educated people that have insurance and that have all the,
Yeah.
and they have clear access to a physician to whom they can talk in terms
Right.
that says whatever.
Right.
So there's like something to me that's in the whole premise that sort of eliminates people from this.
Okay,
That's
you're
all.
making another excellent point, and that is, if people lack education and lack a regular provider,
Right.
probably have some vague notion of this law is out there, but don't know how to actualize it, don't have advocacy in terms of getting themselves into the right place at the right time. So maybe it isn't surprising then that it is the well-insured, well-educated people who take, who use this provision. Which means, of course, that, our healthcare system is even more sinister and corrupt than I typically think it is in terms of its injustices for who can get access to anything that the healthcare system is offering.
I mean, well,
Does insurance tend to cover this?
I think it does. I'm pretty confident that it does in most places. I'm less confident about the medications.
You would think they would,
Well,
if they picked the most selfish reason they could think of, you would think they would cover it.
I'm going to look this up and I'll put this on the web. I honestly don't know if it's covered and to what extent it's covered. I know we've had this huge debate in this country about whether or not a physician could be compensated for even doing some advanced care planning with patients.
It would be the last claim they would ever get, which is why I was suggesting they would probably cover
It couldn't be terribly expensive, I wouldn't think. All right, one more question, and honest to God, I really am going to move on. But you all have such great questions, I don't want to stop.
Okay, so let's suppose my life expectancy is 5 years, but terrible suffering is expected for that whole 5 years. That's the person who most deserves physician-assisted suicide. But the law denies it to that person. Is that true?
That's correct. You got to have, at least in the United States, you got to have a terminal diagnosis, and it needs to be a 6-month span, and it needs to be certified by 2 physicians. So you're right. I have talked with a lot of patient advocates who've said, this is a nice law, but you know, it doesn't help us.
Or else it doesn't help the mentally ill irrevocably. So, and the Alzheimer's who are.
Yep. We're going to come back to the Alzheimer's. Okay. Other countries, physician-assisted suicide and euthanasia are legal in the Netherlands, Belgium, and Luxembourg, and only physician-assisted suicide in Switzerland, Finland, Germany, and the Victoria province of Australia at last count. It's possible that I'm behind on this because things change very rapidly. Okay, now I want to change and talk about the ethics of suicide before we get to the ethics of physician assistance in suicide. So one way to phrase this question is there such a thing as a rational suicide? That is, a person in their right mind, since we have psychiatric overlays on the category of suicide typically, is there such a thing as a non-psychiatric or rational, valid suicide? And then we can get to the question about what about asking physicians to help in this? There is a long tradition in Western culture of what is sometimes called a noble death. And these are my boys, the late Roman Stoics, right? Epictetus, Marcus Aurelius, Seneca, and Cicero. They all held roughly the same view. A good man should not live as long as it pleases him, but as long as he ought. For them, you always live by your own consent. Choosing to die, committing suicide, is then an ultimate mark of your freedom. You have control even over your own life and death. And what they talked about is that death is preferable to slavery, loss of honor, the degradation of self. Now that would mean something different for us than it would for them, I suspect. But I think I asked this earlier and everybody raised their hand. Can you think of a situation that would be worse than being dead? And if you can, then you might open the door just a little to the question of taking your own life. I just want to point out, it wasn't always the case that we had a psychiatric provision or a mental health provision or a sinfulness associated with suicide. There are other traditions which flow into the thinking about this. And here's another example. Not exactly suicide, not exactly physician-assisted suicide. This is Abimelech. Abimelech was one of the minor judges of Hebrew Scripture. He was the son of Gideon, one of many sons of Gideon, and he was not a nice guy. He, in fact, killed off all the other rivals to the throne, which were his brothers and half-brothers. So this is not a person you should feel any sympathy for. But he's staging an attack at the city of Thebes, and you can see in the tower here, this is the last stronghold of the city. And Abimelech is at the base of the tower, and a woman drops a millstone on his head. Here's the millstone. Here's Abimelech. And he said to his armor bearer, who you can see here drawing his sword, "Draw your sword and run me through." lest it be said that a woman killed me. You may not have a big fear of being killed by a woman, but it would be a degradation to a warrior king. Just another example. And there are many, actually, in Hebrew scriptures. The origins of the Christian Orthodoxy, saying that suicide is unlawful and a sin, comes from St. Augustine, who was 3rd and 4th century of the Common Era. He was a bishop in the African province, Bishop of Hippo. And there were, at that period in time, a group of Christians called Donatists who had some peculiar views. One of their views was, in fact, that all the sacraments would be invalid unless the priest was spotless. Now, that would be really, really a hard recommendation to live up to, right? But this was their belief. Another of their beliefs was a kind of a dualistic philosophy which says that this earth, is just a shadow of tears and travail, and we're going to enjoy something really fantastic in the next life. So, one of the things that the Donatists did, not the only ones, and not all of them, but some of them did, they would link arms and run off a cliff. And the idea here is that why wait around, for the glories of the next life? Let's just go. And they thought about themselves and talked about themselves as martyrs. And Augustine said, not so fast. He said, suicide is not martyrdom, it's a sin, and it shows an unwillingness to endure suffering. It's grounded in despair rather than in faith, and it's affront to God's providential wisdom, who's going to call you when he or she is good and ready. So don't take things into your own hands. This is the origins of the Christian doctrine, which infused so much of our legal system for so very long. It was given definitive expression later by another great doctor of the church, Thomas Aquinas. And I chose this slide because you may not be able to read what's written in the scripture. It says, man does not live for himself, but for God. He had arguments against suicide. Now, the fact that there are arguments all the way through the history of the West about suicide means that it happens. It was, if not prevalent, it was at least present and out there. But Thomas Aquinas said there are duties of love to oneself. Everything naturally loves itself, the result being that everything naturally keeps itself in being and resists corruptions as far as it can. Wherefore suicide is contrary to the inclination of nature and to charity, whereby every man should love himself. Hence, suicide is always a mortal sin, that is, the big kind, as being contrary to the natural law and to charity. A second argument he made, it's an injury to the common good. Every part as such belongs to the whole. Now every man is part of the community, and so as such he belongs to the community. Hence, by killing himself, he injures the community, as the philosopher declares. He's talking, of course, about Aristotle. And his third argument, I think there are three, divine prerogatives. Because life is God's gift to man and is subject to his power, who kills and makes to live. Hence, whoever takes his own life sins against God, even as he who kills another's slave sins against that slave's master, and as he who usurps to himself judgment of a matter not entrusted to him, for it belongs to God alone to pronounce sentence of death. I don't know how this squares with your own teachings or your own understandings, but this is, as I say, this is more or less orthodoxy and has been for centuries, and is the basis of most of the statutes against suicide, most of which by now actually have been repealed. I'm not sure why, but I think maybe people thought they were outmoded, or it was hard to figure out who are you going to punish, right? Where did these guys get these ideas? From reading Scripture. Yeah, and from church teachings and from a variety of, it became sort of accepted wisdom. So, yeah, I just wanted you to be aware of at least a major component of where these laws come from and where the kind of moral feeling about suicide, something being wrong with it, comes from. Now, of course, I want to look at the counter-arguments, and then we can talk about them. And I've chosen as my stalking horse here David Hume, the great figure of the Scottish Enlightenment, contemporary of Adam Smith. This is a picture of him actually in his youth. Isn't this great, this cap? Don't you wish this would come back into fashion? Yeah. They were all the rage, believe me, in, 18th century Edinburgh. So he said about this whole business of the injury to the common good, he said, a man who retires from life does no harm to society. He only ceases to do good. And where my life is a positive burden to society, my withdrawal from it is not only innocent but laudatory. It wouldn't surprise you to know that Hume spent a lot of time studying Seneca and Marcus Aurelius and Epictetus, along with Christian doctrine. And he was notorious. Hume was actually denied a university, the most brilliant philosopher of his time. And most people say the most important philosopher to write in English ever. But he was denied university post because his ideas were just a little eccentric to the norm. Okay, what about this divine prerogatives business? He says, well, when I fall on my sword, I receive my death from the hands of the deity as if it had proceeded from a lion, a precipice, or a fever. When pain and sorrow make me tired of life, I may conclude I am recalled from my station in the clearest and most express terms. So what he's suggesting here is once you begin to talk about divine will and divine prerogatives, why not include suicide in that? Okay, I want to move to assisted suicide. And I've chosen this picture because of kind of the irony. Notice who's holding the placard that says, I'm old, I'm disabled, I support choice, and who's holding the anti-legal assistance placard. In other words, people in very different phases of life. But before we get into assisted suicide, let me just ask, any questions about what I've said? My 3-minute run-through of Western civilization with a little philosophy egged in on the side. Glosses on that? I'm happy to hear them. I realize I'm going through massive periods of time and just trying to give you a flavor of some things that I think are important to think about. Yes, sir?
The number of the people that you selected there for their opinions, did any of them commit suicide?
Some of them did. Yes, some of them did. Hume did not. But certainly many of the, who's the guy who wrote the long lives of the ancient Romans? Plutarch, yes, thank you. If you read that, you'll see how many of the greats, of the ancient world actually did commit suicide. So, Yeah, it was perhaps more prevalent at that period in time. Yes, sir.
This nation was formed as a Christian nation. I grew up in East Texas town in the Southern Baptist Church. And I remember as a child, we had to spend most of our time in church, it seems like. They taught us that suicide was the one unforgivable sin.
Yep. Well, you had a very typical Orthodox upbringing then in your East Texas Baptist Church, is what I would say. Yes, ma'am.
Are there any cultures in which this type of thing is the norm?
Well, think about Japanese culture,
Yeah.
where there's a high sense of honor around one's life and a notion of an honorable death. It looks like it would to me. It looks like it would hurt. In India, sati, which means
Which means if your husband dies, it's honorable for you to throw yourself on the funeral pyre.
yeah. I don't know how often that's still practiced, but okay, I want to keep moving. Arguments against physician assistance in suicide. The sanctity of life argument. There are strong religious and secular traditions against taking human life, and assisted suicide is morally wrong because it contradicts these beliefs. That is, the idea that every human life has a sanctity about it, your own included. There's also an argument based on the passive and active distinction. There's an important difference between passively letting die and active killing. It is argued that treatment refusal or withholding treatment equates to letting die, a passive act on the part of the healthcare professional, and is justifiable, whereas physician assistance in suicide equates to killing, active killing, and is not justifiable. So it has to do with who is the agent of death. If it's nature, you died of your cancer, that's one thing. If you died because your physician gave you a lethal prescription, that's very different. That's the idea. And notice how this is all based on a certain notion of natural. What's natural? I want to keep moving, and then if you would hold questions for a few minutes. A second argument, the potential for abuse. I talked a little about this. People are vulnerable. The poor and the elderly, for example, lacking access to care and support may be pushed into assisted death. Furthermore, assisted death may become a cost containment strategy. Burdened family members and healthcare providers may encourage the option of assisted death. And to protect against these abuses, it is argued that physician assistance in suicide should remain illegal. This is essentially the slippery slope argument. Are you familiar with that? One step on the slippery slope and you are soon at the bottom. There can't be any provisions that would work against the sanctity of life, because once we start down that road, God only knows what will happen. And people usually point to the Nazi regime and the final solution as an example of how a train of thinking about people who are unworthy of life can be thought of as burdens to society. People who make this argument are very concerned about that line of thinking. Professional integrity. This is about the physician or healthcare professional, him or herself. An appeal to the historical ethical traditions of medicine. The Hippocratic Oath, for example, says, "I will not administer poison to anyone when asked. And I will be of benefit, or at least do no harm to all the patients I see." So it's not surprising that the American Medical Association and the AGS is the American Gerontological Society oppose assisted death. And they say, this is going to harm medicine's image. If a physician is trying to get you healthy and at the same time willing to dispatch you, right? Thank you. And finally, the fallibility of the profession. Physicians will make mistakes. For example, there may be uncertainty in diagnosis and prognosis about what illness a person has or how long they are likely to live. There can be errors, as I mentioned earlier, in the diagnosis and treatment of depression or the inadequate treatment of pain. The worry here is that some people who would be very successful recipients of palliative care won't get it because they'll jump to assisted suicide as the alternative. A part of this argument is that the state has an obligation to protect people from these kinds of mistakes by regulating physicians in such a way that they won't participate in these things. Okay, the counter-arguments. Those who support physician assistance in suicide say decisions about the time and circumstances of death are very personal. Competent persons should have the right to choose. It's the basic ultimate freedom that everyone should enjoy. Now, the justice argument is very much like the Second Circuit Court ruling. We have to treat like cases alike. Competent terminally ill patients are allowed to hasten death by refusing treatment. For some patients, treatment refusal will not suffice to hasten death, and their only option is suicide. So justice requires that we should allow assisted suicide for those patients. That argument did not win the day with the Supreme Court, obviously, but some people still feel very strongly about it. There's the argument from compassion. Suffering is more than pain. Lots of physical and psychological burdens people need to be relieved of. It's not always possible to relieve suffering. There are some kinds of suffering that cannot be alleviated. Thus, PAS may be a compassionate response to that kind of situation. And this is interesting. It's a little gloss on an earlier one. Individual liberty versus diminishing state interest. Here the idea is that the older you are and the more ill you are, the less the state has a stake in protecting your sanctity of life. In terms of things like years lost, right? But also in terms of, is there less of an obligation to protect a person who's terminally ill than, let's say, a healthy adult or a newborn or a child? This could be a worrisome kind of argument if you take it too far, but people do try to make this argument. Openness of discussion. Assisted death already occurs, albeit in secret. For example, morphine drips ostensibly used to relieve pain may be a covert form of assisted death or euthanasia. That physician assistance in suicide is illegal prevents an open discussion. Certainly true in Tennessee, in which patients and physicians could engage. Legalization of PAS would promote discussion and less abuse. So the idea here is that it's already going on. It's going on in ways that we can't regulate because it's secretive, and therefore the way to prevent abuses is to open this up, give people a legal avenue to do this. And this is an argument from a physician's ethic perspective. The physician's highest duty is not to preserve life at all costs, but depends on the context and the patient's condition and his or her values. At times, the highest duty may be to relieve or prevent unwanted suffering. So there's a place for physician assistance in suicide, and making it legal will not destroy but enhance the trust we would have in physicians. So just the opposite argument. Okay. That's the last slide coming up, and I want to save that for a few minutes and see what kind of questions you might have about what these arguments entail. Any of them particularly compelling? Any of them seem spurious? Yes, sir.
Yeah, I just want to tie back to, I believe, 2 sessions ago. You made the point that when care is refused, care has ended, the relationship between the patient and their physician frequently also ends. That conversation.
Yes, I do.
You know, it's interesting to me because that physician, let's just take cancer as an example. That oncologist, in this case, would likely return to the patient's world as one of the physicians declaring, you know, whatever it needs to be declared, 6 months to live or
Right,
whatever,
right.
I don't know, it struck me. Another question.
No, but it's an important point because the whole question of continuity of care is really an important one because we can imagine that conversations about end of life might be quite different if there was great continuity between a healthcare professional and their patient. For one thing, a lot of these things would be discussed much earlier, and maybe different decisions could be taken. So it's an excellent point, and I thank you for that. Yes, sir.
I just wanted to reinforce that point because my recent experience with my dad's death, I think all the medical people knew that when they started weaning him from the oxygen and giving him the cocktail to make him comfortable, that at the end of the day, he was going to be dead, and he was. And if we had known that, I mean, this was his ultimate goal anyway, because he had chosen hospice care.
Mm.
If we had known that, then more of the family would have been there rather than thinking they were going to have another opportunity when he got transported to another facility. So I think opening it up, letting people talk about it would be much better than what they're doing now.
Yeah, thank you. That's an argument against secrecy and also against the illegality of certain practices. Okay, I want to end by following up on our conversation about advance directives, and this is an advance directive written by Norm Cantor, who's a retired law professor at Rutgers. And I thought this was so fascinating, since both dementia and advance directives are something we're going to take up again. Just a case for the back of your mind as you're thinking about this. This is what is in his directive. If my dementia has produced inability or unwillingness to feed myself, my caregiver should refrain from hand feeding. If I appear receptive to hand feeding, now remember this is in an advanced state of dementia, agitated or upset by non-feeding, I authorize sedation to relieve that upset. Is this okay? Can you imagine writing an advance directive that has this in it? There's a whole series of discussions I want to have with you about how much can the present self dictate what the future self will receive. Remember, one of my great theses, not so great, one of my constant themes is how changeable we are, how adaptable we are. So it should raise, I hope, in your mind some questions about the extent to which the current self can dictate action or inaction for the future version of oneself. So I'm not saying this is a bad thing to do. I'm just saying, to me, it raises a lot of very interesting questions and has lots of implications for healthcare providers and for one's family, who would probably be doing some of this hand feeding. Okay, let's stop. And I'm sorry? I'll try. I'll see. I can't remember what I'm supposed to be doing next time, but But we will come back to this, I promise, because I think this is an incredibly important question. Okay. Thanks a lot. See you next week, I hope.